Greetings, everyone. I'm Dr. Akshita, the ARA Fellow from Apollo Specialty Hospitals, Bangalore. So, today's topic is on the consents and documentation in regional anesthesia and its importance. My moderators are Dr. Vinay Kumar and Dr. Murli TSR. Uh, so, diving into this, looking at the overview. So, the topic will be covered under the following headings: there is introduction, consent, risks of regional anesthesia, documentation, the stop before you block technique, and the postoperative instructions to be given after regional anesthesia, and the recovery scores. Just a just a brief, short situation that occurred in 2000. An interscalene block was performed using a Winnie approach with nerve stimulator at the end of a subacromial decompression procedure before reversing general anesthesia in a patient. And after which he became immediately apneic and bradycardic, requiring several hours of ventilation on the ICU. He went on to develop a significant neurological deficit on the operative side and a lesser deficit in the contralateral arm, ending his career as a concert violinist. So the patient said that he had not been warned about the risk of nerve damage, and while the anesthetist said that he had mentioned this risk, his record of the preoperative assessment made no mention of his intention to use a block at all. So the claim for negligence was likely to go to court, and where the focus would be on the lack of consent. However, an MRI scan carried out about 4 years later in question revealed uh, a, a late developing syrinx in the cervical spinal cord, with this evidence that the block needle had entered the subarachnoid space and impacted the cord. The claim was finally settled out of court, obviously in favor of the patient. So, coming to the importance of introduction after seeing that situation that a doctor had to go through. So, documentation is important for quality improvement, education, and research. It has to be concise and accurate for healthcare delivery and medico legal protection. A proper consent discussion helps build trust between the patient and the physician by ensuring that both parties have had a chance to communicate and clarify the intended procedure, its potential benefits, risks, and also the alternatives available. What is consent? So, to show appropriate respect for a patient's autonomy and their right to self determination. So, and consent is not taken, it is for doctors to seek and for patients to give. Failing in our ethical duty to seek and obtain consent results in legal and societal sanctions, even if the intervention was carried out with the best of intentions. The legal age for taking consent is 18. However, above the age of 12, the whole process of anesthesia or whatever surgery is being performed on the patient has to be explained. So, what is an informed consent? The four conditions for a consent to be informed and therefore meaningful: one is voluntariness, that is, the patient has to give permission freely with no coercion. Disclosure, as in the patient must be aware of all the risks involved. Understanding, that is, the patient must appreciate the nature of the proposed treatment, the risks, and the intended benefits. Capacity, as in the patient must have the ability to contemplate the information and make choices congruent with their future goals. If any of the above conditions are not met, then the choice is not truly autonomous, nor the consent genuinely valid. So, why is consent obtained? Is for good ethical practice, medico-legal importance, and patients want to know the risks, the benefits, and the alternatives for anesthetic that they will receive. So there's something known as nocebo communication, as in you are influencing a patient's decision by emphasizing negative effects, as in providing an extensive review of the risks associated with regional anesthesia, while minimizing the benefits may sway the patient to opt GM. and vice versa if the risks of general anesthesia are overemphasized. What are the risks of regional anesthesia, and how do you explain all of these risks to the patient? The risks related to regional anesthesia can be rare, hence, defining the population incidence can be challenging even with large cohort studies. Furthermore, there can be significant variability in how a complication is defined, how long the patients were followed up after the complication to assess for resolution, the underlying patient factors that could increase their risk, like their comorbidities, and whether the harm is caused by the anesthetic itself or by other factors such as positioning, tonic application, or the surgical procedure. So, all the patients would receive information leaflets that you can follow the link above to uh, go into the depth of these leaflets. So same link is forwarded can be forwarded to the patients coming for an elective surgery in prior. And the leaflet was developed by the RCO Patient Information Group in collaboration with Association of Anesthetists, where it gives you detailed information about all the available modes of anesthesia, the types of anesthesia, what will be done preoperatively, intraoperatively, and postoperatively. And video links are also available, which can make information delivery much easier. So, how do you explain the risks to these patients? People vary in how they interpret words and numbers, so this scale is provided to help. Very common risk can be explained as 1 in 10, that is one person in a family, and common risk being 1 in 100, that is one person in a street, uncommon being 1 in 1,000, that is one person in a village, and rare being 1 in 10,000, where you can explain it as one person in a small town, and very rare as in 1 in 1 lakh, that is you can explain as one person in a large town. Coming to the NAP3 audit that compiled all the complications related to central neuraxial blockade from 2006 to 2007. And they saw that permanent harm from central neuraxial blockade was 1 in 24,000, 60% of which was caused by epidural, 23% by spinal, 13% by combined spinal epidural. And paraplegia or death occurred in 1 in 50,000 patients. So the risks that came along with the procedure of central neuraxial blockade, that is spinal or epidural, included headache, that was found to be 1 in 100 in each, and bruising or local pain with discomfort was found to be 1 in 10 in each spinal and epidural, and infection was 1 to 3 in 1 lakh in both of them. And spinal hematoma seen after an atraumatic puncture was found to be 1 in 3 lakh 20 and 1 in 2 lakh 20 in spinal and epidural, respectively. And traumatic after a spinal hematoma after a traumatic puncture was found to be 1 in 29,000 in spinal and 1 in 20,000 in epidural, whereas transient neurological symptoms occurred in almost 1 to 2 in 10 patients who received lidocaine in spinal. Peripheral neuropathy, which is usually transient, occurred in 1 in 10,000 in patients who received spinal and 1 in 1 lakh patients who received epidural, whereas permanent peripheral neuropathy occurred in patients 1 to 2.2 patients in 1 lakh and 4.8 to 9.6 patients in 1 lakh. And death occurred in 0.6 to 1.2 in 1 lakh and 0.3 to 4.8 in 1 lakh in spinal and epidural anesthesia. Coming to the risks of peripheral nerve blockade. So accordingly, the most of the postoperative neuropathies were found to be transient, and the ASTRA 2015 guideline on neurological injury outlined that peripheral neuropathy occurred in 0 to 2.2% patients at the end of 3 months, 0.20 0 to 0.8% patients at the end of 6 months and 0.2% at the end of 1 year. And the second ASRA evidence-based assessment of ultrasound-guided regional anesthesia 2016 showed that long-term incidence of postoperative neurological symptoms were 5 in 10,000 patients. So the upper limb and lower limb blocks were studied and found that the bruising, local pain, and discomfort was most in axillary and popliteal, femoral, and ankle blocks. That was 1 in 10. And the infection rate was pretty much the same in all of them. That is 1 in 10,000. Horner syndrome was seen mostly with interscalene blocks, so that was seen with 1 in 10. And peripheral neuropathy, which was transient, was found to be 1 in 10 in all of these blocks and 1 in 10,000 in most of these blocks, except intraclavicular block, that is 1 in 1 lakh. And respiratory failure as under interscalene block was found to be, in patients under interscalene block, was found to be 1 in 10,000. So what you include in your consent and how in your consent while taking it from the patient. So patients must be provided with the evidence-based information in the form of a pamphlet far in advance of the anesthetic, and the specifics around consent discussion has to be included by the ACB 2017 guidelines. And the benefits of RA, such as early mobilization and less PONV, should be mentioned. Process of regional anesthesia, that is the use of ultrasound, needle insertion, and use of peripheral nerve stimulator, has to be explained. Other alternatives to regional anesthesia, such as general anesthesia and sedation, must also be explained to the patients. The use of analgesics as the block begins to regress can be mentioned to the patient. And also all the risks involved, such as including block failure and any common risks, less common but serious risks like pneumothorax and peripheral nerve injury, have to be mentioned to the patient. This is a format followed by the AORA India. So the informed consent contained the patient information that included name, age, sex, hospital ID, along with the date and time, and all the techniques of general anesthesia, spinal or epidural anesthesia with or without sedation, nerve blocks or facial plane blocks with or without sedation, and in IVRA with or without sedation, and MAC with or without sedation. The technique itself, the expected results, and the risks have to be explained briefly, along with the fact that the past medical problems, past medical comorbidities may increase the risk during and after surgery has to be explained to the patient. Finally, the neurological deficits that were already present, that can be motor or sensory, and other medical comorbidities, and the ASA status accordingly should be mentioned. And the anesthetist should sign and write his or her name against date and time with the surgical procedure planned and the regional anesthesia procedure planned for the same, and how you prefer doing it. That is ultrasound guided, peripheral nerve stimulator, using a peripheral nerve stimulator, or landmark guided. In the presence of a witness, the patient will sign with his or her name and age and sex with against date and time. So how can we improve the consent process? You can be brief, use simple short explanation, which helps recall of the risks and benefits more than lengthy paragraphs. Include not only serious and major risks, but also benefits and the expected results of the proposed regional anesthetic procedure. And it is difficult for patients to make an informed choice if only risks are discussed. So use the consent process as a means to educate the patient simultaneously. Offer a copy of the form to the patient. This has been shown to aid in recall of consent-related information. So coming to documentation. As we know, documentation of nerve block procedures has lagged behind mostly compared to documentation of general anesthesia. You'll probably just see the block mentioned in a corner of your PS intraoperative procedure notes. But Pressure from legal, billing, and regulatory sources effort made help to put in an effort to improve documentation of peripheral nerve blocks. Paper records are continuously being replaced by electronic medical record keeping system. So another useful way to keep your records is by recording your ultrasound image or video clip to be stored as a digital copy in your health records against patient's name and details. So the modified Delphi consensus gave a couple of recommendations for documentation in regional anesthesia, showing a few uh, information which showed level of agreement being strong. So starting with patient information like name, date of birth, gender, medical record number, hospital number, the weight, height, ASA physical status, and allergies showed strong levels of agreement. And the procedure preparation, that is the block performed by, as in the name of the person forming the block, the grade of the block former was found to be a weak level of association. Name of a supervisor, documentation of the patient consent gained or not, documentation of the individual risks of the procedure discussed or not, the PSC check or the pre-block evaluation, the coagulation was considered, and pre-procedure diagnosis such as post-operative pain management or surgical diagnosis, timeout done or not, that is your WHO checklist, stop moment, that is stop before you block, was performed or not, whether an intravenous access was secured, regional anesthesia procedure name, the patient position during RA procedure, monitors, the ASA monitors were applied or not, the baseline vital signs recorded, the pre-medication that was used with sedation. So the procedure performance, that is your time and date of procedure, the aseptic agent that was used, the aseptic technique used as per local policy or not, skin infiltration with local anesthetic, the needle design, that is your tip manufacturer, length and gauge, and the local anesthetic used for regional anesthesia technique, along with the concentration and volume, the epinephrine dose if used, or an adjunct if used. Uh, these were the specific documentation required for peripheral nerve block performance. That is the side of your block, technique of needle localization, that is ultrasound or nerve stimulator or landmark guided. Whether there was no evoked motor response if using a peripheral nerve stimulator, uh, and the minimum current or the current duration, again, if using a peripheral nerve stimulator, absence of blood on aspiration, the depth of catheter at which you've inserted, and absence of pain or paresthesia during injection, and the complications. Few few documentation with specific for neuraxial procedure performance, that is the technique, the level of vertebral in needle insertion, the technique used for loss of resistance to saline or air if epidural is being used, the number of attempts you've taken, epidural needle depth at loss of resistance, and catheter depth at skin, note on aspiration and the action taken, epidural test dose in case you're giving one, and absence of pain or paresthesia during injection, the final dermatomal level of spinal or epidural block achieved, and the complications again. Post procedure, you record the vital signs after the procedure and post procedure instructions to give your nurses. This is a former for your regional anesthesia procedure form that includes date, time, and the consultant who's requesting the block, and the pre-op diagnosis, the surgery that you've planned, purpose of the block being surgical or post-op for post-op pain, and the block procedure location, that is your OT or your block room or your pre-op area, the whether the ASA monitors were connected, oxygen connected or not, and the pre-medication that you've given with the level of sedation that you've given, the name of the block procedure and how you're planning to do it. That is ultrasound guided or nerve stimulator guided or landmark based. And whether you're planning to give a single injection or thread in a catheter that is continuous. The type of needle or the catheter that you're using and the sterility that you've followed, the local anesthetic or the additives that you've used with type and concentration and the volume. And finally, the procedure notes, as in have you used a local anesthetic to infiltrate skin, patient position, the depth of needle, and the minimal current if using a peripheral nerve stimulator. And if ultrasound guided, if you're using an in plane technique or out to plane technique, and ca- on localization of your catheter tip using the ultrasound or motor stimulation, and the depth of the catheter at skin, whether you've aspirated and you saw blood on aspiration or pain on injection or injection pressure was less than 15 psi or not. Finally, you sign and your attending or your consultant signs and you mention the date and the time. This is just the same. This is an electronic record of the same. That's all. So coming to stop before you block. So in 2010, the Nottingham University hospitals came up with this stop before you block. Despite this, wrong-sided blocks remained at 1 in 66,250. So they came up with a newer approach. There was a standard operating policy where step 1 was prep, step 2 was stop, step 3 was block. So in prep, the WHO sign-in was done. The blocker or the anesthetist prepared the local anesthetic solution and placed it in a suitable nerve block needle with a suitable nerve block needle in a dedicated tray or a container, which was handed over to the assistant out of the blocker's reach. And the preliminary scan was done, and the blocker donned gloves and prepared the site for the block. In step 2, that was stop, it was a 2% step done just before needle insertion. Both blocker and the assistant checked the block site by confirming site mark and consent. And if the patient was awake and unsedated, they also confirmed the block site. And in step 3, that is you block. The assistant hands over the tray over to the blocker to perform the block immediately. And any delay in performing the block required them to restart the stop before you block process at step 1. So coming to your post-operative management, you always accompany patient during transport from OR to PACU. Provide the essential post-operative care information to the nursing staff, continuing the patient care. Reinforce the verbal and or written information to the patient about care of the blocked extremity. And ensure adequate instructions for post-operative analgesia after the block regression. So how do you educate your patient? First, you tell them that it's normal for your arm or your leg on the side that you had surgery to feel numb for 6 to 24 hours, as in it may feel heavy, tingly, or weak. And it is normal for the medicine to begin to wear off between 6 to 24 hours. It's usually 12 hours in most of the patients. And once the block wears off, the pain comes back very quickly. And so you must take your pain pills once you notice this, as the medications take at least 30 to 60 minutes to take effect. It is normal to have to take your pain pills more frequently once the numbness wears off. And often the nerve block can wear off in the middle of the night. Therefore, take your medication before you go to sleep as recommended by your doctor. What are the do's and don'ts? So you always keep your sling or brace on while the limb is still numb, unless you're doing physical therapy. And after physical therapy, you put back your sling or brace as recommended by your surgeon. And in the next 24 to 48 hours, check the needle site for any redness, swelling, excessive tenderness, or pus. And always, in case a catheter is placed, you have to emphasize on the maintenance of sterility. So do not, all the don'ts that you have to mention to your patient, that do not drive or operate any dangerous machinery because your limb is still numb and it may make it difficult for you to control your arm or leg while the local anesthetic medicine is still working. Do not apply any pressure, heat, or cold on your numb areas except as directed by your doctor. And because you would not realize if your limb is being injured by heat, cold, or pressure. So protect your limb like a baby. If you have had a nerve block for surgery on your leg or foot, do not bear weight or walk using the affected leg without assistance until your sensation has come back. The local anesthetic can make the limb weak, and if you have had a nerve block affecting your leg, ask for help before rising or walking to avoid any falls. So when do you ask your patients to call you immediately? The injection site has signs of infection, or there's any ringing, rumbling in your ears, a metallic or funny taste or numbness in your mouth or on your lips. If there's any dizziness, agitation, nervousness, hives, irregular breathing or heartbeat, shortness of breath or chest pain. So coming to the last part of the discussion, that is our recovery score. There's PACU bypass. That is a PACU bypass mostly achievable in almost 90% of the patients receiving regional anesthesia exclusively. And for this, we use something known as the wake score, which is a tested criteria incorporating both physiologic parameters and immediate symptomatic outcomes for both regional anesthesia and general anesthesia receiving patients. It incorporates the original regional anesthesia PACU bypass criteria along with the traditional modified Aldred score, the White Song fast tracking criteria, and the Mayo modified discharge scoring system. And it also has an additional zero tolerance criteria. We'll look into this in the further slides. So, what are the parameters in your wake score? That is movement. If there is any purposeful movement of at least one lower extremity and one upper extremity, scored 2. Purposeful movement of at least one upper extremity and neither lower extremity, scored 1. And no purposeful movement, scored 0. And blood pressure in sitting and supine positions within 20% of the preoperative baseline and not orthostatic, scored 1. Within 20 to 40% of the preoperative baseline and not orthostatic, scored 1. And less than 40% of the preoperative baseline and or orthostatic, scored 0. And coming to the level of consciousness, awake and easily aroused by single stimulus, and the patient follows commands, the score given was 2. Arouses to repeated or continuous stimuli with protective reflexes and following commands, scored 1. If a patient was obtunded or persistently somnolent with plus or minus protective reflexes, scored 0. So the respiratory efforts wherein the patient coughs and deep breaths freely, takes deep breaths freely and or on command, scored 2. Involuntary cough only or an unsupported airway, scored 1. Tachypnea, dyspnea or apnea and or requiring airway support, scored 0. Oxygen saturation of more than or equal to 95% or pre-op reading -2 without supplemental O2, scored 2. More than or equal to 95% or a pre-op reading -2 with supplemental O2, scored 1. Less than 95% or pre-op reading -2 plus or minus supplemental O2, scored 0. Coming to your last bit, that is before that, sorry. Any score of 8 or higher, along with meeting all of the zero tolerance criteria, which I'll discuss later in the next slide, is sufficient to qualify for a phase 1 PACU bypass after outpatient surgery or to fast track phase 1 PACU discharge when transferring the patient to an inpatient non-monitored bed is planned after surgery. So for patients with obstructive sleep apnea, a score of 9 was recommended out of 10. So what was the zero tolerance criteria for the wake score? They had 3 points, that is pain as appropriately adjusted to patient's baseline scores with movement at the surgical site, PONV as a yes or no assessment, shivering, pruritus, and or orthostatic symptoms, that is lightheadedness and or hypotension in the sitting position. So this was the final part of the wake score. So um, I hope you all get to see this and go through the slides, and any feedback is accepted. Thank you.